right, next up we have Kartik Iyer. Kartik is a developmental neuroscientist and biomedical engineer based at the Queensland Institute of Medical Research in Brisbane. His work focuses on advancing how we monitor and understand brain health in children, with a particular emphasis on neurodevelopmental disorders. Kartik's multidisciplinary background spans child development, neurotrauma, clinical neuroscience, and brain mapping. He applies these diverse skill sets to study how the brain and body develop and interact across early life. His research aims to develop accessible, objective tools that support early identification and tailored intervention for children at risk. Kartik will talk to us about next-generation EEG methods for improving diagnostic and prognostic monitoring of child brain health. Thanks. Please join me in welcoming Kartik to the podium.
Thanks, Lena. Hi, everyone. Okay. So I thought I'd start this topic with a bit of scene setting on the global context of child brain health monitoring. There was a report by the World Health Organization which brought together policymakers and eminent scientists in the field to formulate a global strategy to directly address early brain health monitoring challenges. Now, brain health, which is a construct of cognitive, social, and sensory development, is really mediated between early life experiences, whether they be positive or adverse, on long-term developmental challenges, but also disease risk in adults and functional outcomes across the lifespan. And what we know in children is that it's the opposite to what we study in adult and mental health brain disorders, in that it's not so much accelerated aging that we're interested in, but monitoring for delayed maturation or dysmaturity. And this report essentially proposed 3 tiers of measurement. So with early and accurate identification, we're able to alter a child's trajectory dramatically, but without effective intervention, kids will follow a very delayed maturation. So at the population level, you have screening tools and observational and behavioral measurements, and at the individual level, you have what we all work on with neuroimaging modalities. And so hopefully, what I'm hoping to convince you of in this talk is that there's a role for EEG in child brain monitoring, not only at the individual level, but also at the population level. And it's a grand challenge, but with the rise of wearables and at-home monitoring, I think it's very possible. So our local work is making some headway to do this, but it isn't a beaten track, and there's a lot of work to be done. And so we've been busy with tools such as physiological aging with using EEG, but also in cardiac, with ECG as well, and then developing applications using head models for pediatric clinical EEG. But also we have clinical trials that are testing AI-based seizure detection algorithms in the neonatal intensive care unit. And in parallel to all of this, we use these tools to expand our mechanistic understanding of neurodevelopment. So we come at this with a fairly different lens, I think, as much as our work starts at the bedside in the clinic, whereas most of this forum may start this way. But we start at the bedside with the clinicians first, and it's a switch that we've had to be accustomed to for a few reasons. And so I think there's 2 reasons for this. One is partially bureaucratic, but it's also mainly because we have to be able to scale our tools in a way that meets population needs, and even if we are targeting certain disorders. Now, co-design, I'm sure you've heard of it, but if you haven't, it's probably something that you need to engage in closely if you work with clinicians. And extending on that idea, if you really see yourself as a researcher, then it's important that you see yourself as a product developer in this space as well. It's sort of an undeniable truth that if you want to see the uptake of your tools, you have to start thinking about who's using it and what the gaps are in them not using it. And then there's tapping into the idea of data silos, which is some effort in of itself. It really does depend on friendly clinical collaborations, and environments, and lots of discussions that enable the type of large-scale data sets that you might need to take things to scale. And all the fun that entails that can keep you busy for days just looking at the types of data that you work with. Okay, so once we have all this data and we understand the constraints that we're working in, we can hone in on what types of tools that we can actually develop. And with clinical data from standard care monitoring, we have to use limited channel EEG. So 19-channel EEG is typically done in the neurology clinic, and a reduced form of the EEG in 3 channels with sleep studies. But with sleep, we do have the benefit of multimodal data. So that's that type of data that's distracting but can come in useful later. So for children who come into the neurology clinic, whether it's a referral from their primary care physician or pediatrician, they're often encouraged to sleep. And especially in young children, it's really hard to acquire resting state EEG, as you can imagine. But with sleep EEG, these are really well-defined states of cortical activity. And in both sleep and neurology, one particular state that is very well known is one particular state that's very well known is non-REM sleep in N2 sleep, which has these characteristics of spindles and K complexes. And these signatures can be identified as early as 1 month of age, right through to adulthood. And it's also used in these fields to actually specifically identify pathological signatures of activity as well. And aside from all these states, aside from this particular sleep state in particular, there's also N3 or slow wave sleep and REM sleep as well, which is also diagnostically relevant. So the role of EEG and its quantitative features of amplitude and spectra in its relationship to development has been known for a long time. But with well-defined clinical EEG, we can really get a sense of the type of fidelity of quantitative features in the EEG waveform. So here with N2 sleep, we really see these remarkable trends that allow us to explore what types of feature types might explain an age of the child the most. And you can see here that amplitude and frequency and informational measures such as entropy or dimensional measures explain a lot of the age-related variance. And I think the arguments for EEG to be looked at as a mirror to well-established structural changes across the early part of the lifespan are there to be made. You'd expect these things to change as a function of things like head circumference, but beyond that, there is a functional convergence that's orthogonal to structural development. So going back to the application end of things, how can we use all these age-related features to predict age successfully? And using supervised learning approaches, we did this using our clinical data sets in a typically developing cohort using 15 minutes of sleep EEG collected in the neurology clinic. And then we validated against an independent data set of 723 children with sleep studies. And in fact, we contrasted our Gaussian process regression approach, which is on the right, with a convolutional neural network approach, just training purely on the EEG waveform itself. And turns out, perhaps no surprise, that the neural networks do win out, but it was fairly close. What we found was that our approach with the brain age estimated from the neural network had a really high correspondence with chronological age, up to R-squared of 0.95, and extremely good mean absolute errors, which were proportional to age. You can see in the right-hand plot that the error band, particularly in the blue, tails off from months in infancy in error to about 1.5 years in error by adolescence. And during validation, what we could see is that we could track the types of EEG features that were most affected between our 2 sites. And to explain this figure just briefly, many of the features that are in green were common between our sites. So the x-axis is age, and the y-axis is our different types of EEG features. And the key takeaway here is that whilst many of these features stay the same between sites, some features in younger groups looked a bit younger, and some features in the red looked a bit older. So there are some challenges that we have to deal with in terms of site harmonization, particularly as we grow our training sets. But we also felt this is a very good platform to start thinking about the things that clinicians in the field utilize, things like growth charts, for example. So we thought, why not build a growth chart of the EEG and see what comes of it? And in combining our data sets, we found a very acceptable accuracy. Importantly, the growth chart was sensitive enough to detect changes between typical development and children with trisomy 21 or Down syndrome. And when we ran over simulations across age with other growth charts, we were able to establish that the growth chart of the EEG sat within the accuracy limits of pediatric measures of head circumference and height. Okay, so yeah, this is an open source development tool that it's in the early stages of development, but we've got our first iteration out with our collaborators, and they've started to test this with our clinical data sets. Now with the sleep EEG, we trained our brain age tool to only on 15 minutes of EEG per subject. But with specific sleep stages, we can begin to start leveraging the entire sleep cycle. So here, instead of 15 minutes, we have around 8 hours of data to work with and train on. And despite not having many EEG channels to work with, what we're aiming to tap into is a temporally rich signal. You can see this example of a 10-year-old child and how the brain age predictions oscillate with changes in sleep state every 30 seconds. And the resolution of brain age actually across the entire night from just a 3-channel model actually gets closer to converging with a 19-channel EEG when you look at the specific age bands. So by leveraging this sort of temporal scale, we can actually offset the potential loss of spatial scale in terms of a global brain age estimate, purely by having a greater amount of temporal data. We can also use our neural networks in a really flexible way. You can see from this example here that the brain age predictions are potentially picking up something closer to perhaps sleep state cycling. And so we tested this. In the top contingency table here, what you see is we trained the EEG to initially predict age, and then we modify our last few training layers to actually predict sleep state. So instead of predicting age, we're actually capturing state-based changes. And we compared this to a sleep state classifier. And as you can see, the comparison is that brain age is picking up a lot of this sleep state information. So the broader question that we're trying to explore from here is, what could these sleep-related age predictions entail for diagnosis or prognosis? Perhaps a child who's having poorer sleep or dysmature EEG would typically have a reduced capacity to recapitulate sleep stages. And building on to this with explainability of the neural network with our EEG features, we can see a high level of correspondence across the night between the last few layers of the neural network with our EEG feature sets. Okay, so the advantage of having so much data is that you can start to build and test models with cohorts of clinical interest, particularly looking at from the onset of sleep to the end of sleep, thereby isolating periods that carry the most diagnostic or prognostic relevance. And in our case, we contrasted our typically developing children with about 300 children with neurodevelopmental disorder diagnoses. And what we could see is that some key EEG features that are clinically relevant or relevant to the clinician whilst they're actually scoring sleep studies in these children can actually be used to optimize and reduce false positive rate and true negative prediction. So this is potentially a really exciting avenue for screening children who may be at risk, or even further examining the trajectory of development as they participate in interventions. And so further work in this area may yet reveal that the relationship of EEG features that are clinically relevant with developmental age. And in the bottom right, what you can see is the correlation of age of typical developing children versus children with neurodevelopmental disorders. It's not necessarily monotonic. There are some transitions with these spectral features that differ in children with neurodevelopmental disorders compared to the typical population. We've also started to examine the relationship between brain age and autonomic function as well. So we have an application that looks at beat-to-beat variability in the ECG and training that to predict ECG age. And what we found in preterms was that ECG age is strongly correlated or tightly coupled to brain age, and that could be used to track outcomes. And we've also recently expanded this to from infancy to adolescence as well. Okay, lastly, just going back to the expansion of our tools, spatially we've seen that brain age is also region dependent. And this work, led by Nathan Stevenson, found that in the preterm, frontal regions were functionally more mature than occipital areas, representing a bit of a divergence of what's traditionally understood from structural imaging in the same developmental age range. And in emulating these approaches, we hope to really map out this into infancy and adolescence as well, with the capability to offset the challenge of lower density clinical EEG with more spatially attuned head models that can enable brain age estimation. Okay, so I'd just like to thank James Roberts and Nathan Stevenson, the close collaborators of mine, and also Anton. I've highlighted these three because they're at the conference, but yeah, thanks to all who involved in this project.